G'day everyone, welcome once again into the Radiopedia reading room. I went for a little Australian kind of vibe there Kayla. G'day, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon. The intro music isn't long enough to cover all this. And joining me, is it tertiary Frank? Is it secondary Frank? No, we've got the OG primary Frank. It's my co-host Frank Gaylard.
Hello, Dixon. Is that some kind of veiled syphilis reference?
No, only if you want it to be. It's a reference to another disease, though, that has primary, secondary, and tertiary forms. Can you guess what it is?
Well, if it's a disease, it's not education then. I guess TB? I don't know that there's a tertiary form of TB, though. There probably is.
No, but TB would be a good topic for a future episode.
Oh, TB is a great topic.
Yeah. Today, though, Gaylard, it's a readful episode on the imaging of primary hyperparathyroidism. And as much as you and I like to banter up the top of these episodes, this is a long one. So I think we should actually just get straight into it. This was recorded 3 or so months ago now for the Radiopedia 2025 virtual conference. It's me reading the Radiopedia article on parathyroid adenoma to the one and only Christine Glastonbury, plus a bonus special guest towards the end, Gaylard. In fact, there were 2 special guests during this recording. One you'll actually hear in the podcast, and the other was just for those watching live, and that was my dog Pearl, who walked into the room. She kind of looked towards me and the camera, then settled down on the couch for a lovely sleep, just for the whole 60 minutes or so. She was like, oh, he's doing that thing where he talks to the corner of the room again. I'll just have a sleep.
Oh, Pearl is an excellent judge of character and the smiliest dog I've ever seen.
An excellent judge of when to have a sleep, or when your owner is not going to be engaged with you for an extended period of time. Anyway, let me get into it. So parathyroid adenoma, ultrasound, 4D CT, a bit of nuclear medicine for you, Frank, which you'll love. So the next voice you'll hear will be mine again via the wonders of time travel. Joining me now all the way from San Francisco, it's academic neuroradiologist, professor of clinical radiology, educator, and head and neck guru. It's Christine Glastonbury. Welcome, Christine.
Thank you, Andrew. That is such a great introduction. It's really good and really fun to be here again.
I think I copied that introduction from the last time I had you on the podcast, so just reuse it. So thank you for your lecture earlier in this session on post-radiation effects in the neck. But instead of us discussing that now, we've decided to shift gears entirely to a totally different topic. So we're going to be chatting about parathyroid adenoma imaging, or another way of saying that would be the imaging investigation of primary hyperparathyroidism. Now, Christine, we selected this topic today actually because last year on the podcast, we discovered that we share a common love, and that is a love for the reporting of 4D parathyroid CT.
See, you mentioned that you love something, and look what happens. You get into more trouble. No.
Right.
I really do love it. It's a great topic.
Excellent. So I will be reading today the Radiopedia article entitled Parathyroid Adenoma, as it looks as of July 2025. It may change in the future. And Christine, your job will be to chime in with any words of wisdom that you feel like adding as I go along. Sound like a plan?
Sounds like a great plan. Let's go.
Just quickly before I start reading, I should foreshadow I have a very special guest planned to join us towards the end of this discussion today.
Oh, this sounds really good. I can't wait.
Let me begin with the opening paragraph. Parathyroid adenomas are benign tumours of the parathyroid glands and are the most common cause of primary hyperparathyroidism. Imaging is essential for preoperative localization, helping identify ectopic or multiglandular disease and facilitating minimally invasive surgery.
That is such the perfect introductory paragraph. And this already sets the stage for how parathyroid imaging is so different to every other thing we do as a radiologist, because you're not trying to make a diagnosis. They have the diagnosis. You're like the where's Wally, where's the Waldo, where is the adenoma? So it's kind of fun.
Yeah, absolutely. That's what I love about it too. I'm sure we'll talk about this a little bit later. So we're off to a good start then. The next section is terminology. So primary hyperparathyroidism was traditionally classified as being due to either a parathyroid adenoma, typically solitary, or parathyroid hyperplasia involving multiple glands. However, this distinction, based primarily on the number of enlarged glands, has proven unreliable on histology, especially when multiple glands are involved. The WHO classification of endocrine and neuroendocrine tumors discourages the use of hyperplasia for primary disease and instead recommends the term multiglandular parathyroid disease, which includes multiple adenomas, for example, in MEN, and diffuse clonal proliferations. The term hyperplasia is now reserved only for secondary and tertiary hyperparathyroidism.
So this is a really good change in the terminology. And I remember when we started writing some papers about our experience with 4DCT and looking at the pathology, we were looking to see how good we were, how accurate, where did we make mistakes, why did we make mistakes. And when you read the path reports really carefully, it got really confusing about what pathologists were calling hypercellular lesions. When did they call it adenomas? And it turns out that pathologists actually have a lot of problem and with actually calling adenomas at time. And they really have trouble differentiating hyperplasia for adenomas. And so it kind of gets really, really murky there. And so this idea of now we're just looking at an enlarged gland that we call a parathyroid adenoma is kind of the most helpful, because they will then say that in the context, with a hypercellular gland, in the correct clinical context, this is consistent with a parathyroid adenoma. And at our place, the correct clinical context is that that is the only gland that is enlarged, A, and B, that the PTH drops intraoperatively when they remove it. I like that we've moved away from this hyperplasia adenoma. We just call them all adenomas, and pathologically, they just describe hypercellular glands. Does that make sense?
It makes perfect sense. Yeah. So when we're dealing with primary hyperparathyroidism, we don't need to use the term hyperplasia at all. It's either, if it's one gland, an adenoma, or if it's in multiple glands, we call that multiglandular parathyroid disease. And that makes perfect sense to me
Perfect.
because on histology, I think they are all kind of these monoclonal proliferations of cells. Now, as an aside, I want to mention that I think this terminology section in Radiopedia articles is one of my favorite kind of sections, because when it's present on an article, it kind of means that there is a common misconception out there that radiologists need to be aware of. And so if everyone wants to be up to date and on the same page, whenever you spot one of these, terminology sections on a Radiopedia article, give it a read, okay? Because especially if you're the kind of person who likes to say, well, actually, the term hyperplasia is no longer.
Oh, you're that kind of person.
Frank Galen is that kind of person. All right. The next section here is epidemiology. So let me read. Parathyroid adenomas are most common in women over 50 years of age and are usually sporadic. Associations. Prior neck irradiation is a possible but weak risk factor. A minority are associated with hereditary syndromes, including MEN1, more often multiglandular parathyroid disease than adenoma, and MEN4.
Perfect. You're absolutely right. Most of them are sporadic. If we have anybody who is, say, under the age of 50 at our place, they get referred for genetic consultation as a routine. And sometimes they've already had the consultation before they come to the imaging, but it's just something to keep in the back of your mind. If you hear somebody is under the age of 50, think, oh, maybe they're one of these syndrome patients, which means that they're more likely to have multiple lesions. So keep that in the back of your head when you're reading these scans. And that's why you care about if they're MEN1 or MEN4 or even MEN2A can have parathyroid adenomas.
All right, let's move on to the next section. So, this one is clinical presentation. So, many patients are diagnosed asymptomatically through biochemical screening. Symptomatic cases reflect primary hyperparathyroidism and the effects of elevated calcium and parathyroid hormone, including bone pain, fractures, renal calculi, constipation, pancreatitis, and neurocognitive symptoms. Symptom severity does not always correlate with calcium levels, and normocalcemic variants may occur. Rarely, parathyroid adenomas present with spontaneous hemorrhage, which may be large and cause airway compromise. I've actually got an anecdote about this last point here. So, at the conference a few years ago, I showed this case of spontaneous retropharyngeal hematoma. It happened at my work and I had to report it. So, I presented it, said the cause was unknown, and that was that. And my major teaching point was really recognizing that it was hemorrhage rather than a mass or an infected collection or something. Anyway, a clever person in the audience during that session suggested that it might be a parathyroid adenoma that bled. And you know what? When I look back and where that hemorrhage was centered, I absolutely think it could have been an adenoma. And until that moment, until that conference, I was not even aware that that's what could happen. So there you go. That's how I learned about parathyroid adenomas and massive spontaneous hemorrhage.
That's a great story. You are never going to forget that now. And of course,
No.
you're telling it here. I have one of those cases with a similar big hemorrhage, and that's how I learned that it can be like that. And I have a second case, but I haven't got any path on that yet. But yeah, they
Yeah.
certainly can do this.
Moving on to the next major section here, which is pathology. So, parathyroid adenomas are usually composed of chief cells, though oxyphil and mixed types occur. Most are solitary, up to 87%, well circumscribed and oval or bean shaped. Larger lesions may be multilobulated. Atypical parathyroid tumors, previously known as atypical adenomas, show some features of carcinoma but lack definitive invasion. All right, moving on to this next section, which I think is a very important one, location. So most parathyroid adenomas are found immediately posterior or inferior to the thyroid. Superior gland adenomas lie in the tracheoesophageal or paraesophageal space, while inferior gland adenomas have more variable positions due to longer embryologic descent.
So I know you just said the word embryologic, and half the audience just went, oh, right. It is actually kind of relevant here, not for finding adenomas, but for understanding why they're going to be in the crazy places they are. So the superior glands arise from the fourth pharyngeal pouch with the thyroid glands. So they don't have that far to migrate, and they kind of migrate down the posterior aspect, whereas the inferior arise from the third pharyngeal pouch with the thymus. And so they have much further to descend, and they are much more likely to be ectopic because of, well, it's believed to be because of that further distance. And they're also more likely to go more anteriorly inferiorly. So when you think of mediastinal ones, most often they're anterior mediastinum. And you think about where the thymus is, that kind of makes sense with that. So that is kind of helpful for remembering. But yeah, embryology, people are like, oh, glaze over a little.
Yeah, those pharyngeal pouches, raising their confusing little heads again. All right, continuing on here. So, supernumerary glands, more than 4, occur in up to 13% of individuals and may contribute to persistent or recurrent hyperparathyroidism if unrecognized. Ectopic adenomas account for up to 5% of cases, with locations including, and we have a list here, so mediastinum, usually superior mediastinum, carotid sheath, retropharyngeal space, intrathyroidal, and submandibular region, which is less common. Christine, have you seen ectopic ones in all of these locations listed here?
Not in all of those, and I'd love to see if you have cases on Radiopedia of these. The anterior mediastinum, usually superior anterior mediastinum, totally seen a lot of those. We just mentioned before that the superior ones like to be in the tracheoesophageal groove. I've seen some of the superiors track all the way down into the posterior mediastinum along the esophagus. Not seen a carotid sheath one. Not seen a submandibular one. Retropharyngeal all the time, and they're really kind of satisfying because they're almost impossible for people to find on ultrasound. So
Yeah.
you kind of it's a good place to look, superior mediastinum and retropharyngeal, because they're hard to find on ultrasound. And then intrathyroidal, sure, these are really tricky because thyroid lesions can have weird enhancement patterns, just like parathyroid adenomas. So when I can't find an adenoma anywhere else, and I'm worried about maybe this is it, or maybe that corresponds with the cestomebi, then what we usually do is a preoperative FNA and test for PTH on those. So yeah, you can get them just about anywhere.
Yeah, yeah, your experience matches mine. So the ones I've seen and the ones I haven't seen, and definitely I've seen very posterior ones in the superior mediastinum. So those what are presumably superior glands way down posteriorly in the superior mediastinum. Okay, I'll continue on here. No, actually, I had a little comment here about the 5% ectopic rate. So, because 5% ectopic sounds interesting to me because I mainly report 4D CT at an institution where ultrasound and sestamibi are used as the primary investigations, and then CT is only ordered if they can't localize the lesion on those modalities. So, of the 4D CT scans that I end up reporting, the number which are ectopic, I think, is way, way higher than 5%. I feel like I'm constantly searching for ectopic glands.
You've hit the nail on the head, and this is why different radiologists feel that the experience is really different. Is it depends what study is done when the patient is sent to you. So
Mm,
when we started doing 4D CT, we only did it for patients who had non-localizing SPECT, sestamibi, and ultrasound, or if they're discordant or they'd been prior surgery. And they're the hardest ones. And yeah, you see ectopics all over the place. Cases when we started doing these were always really complex and weird ectopics, as you're talking about, more than
mm,
5%. Um, and then we now have a ton of patients being referred who often only have planar nuke med study, not SPECT. So, which is nowhere near as good. So they haven't found a lesion or they haven't got anything and they haven't got an ultrasound. So I feel like now I'm getting more garden variety ones because they're kind of
mm.
unselected instead of selecting out the easy cases. So I often end up doing a 4D CT. There's no sestamibi. They haven't yet had their ultrasound. There's nothing at all. And they're often like really boring, normal location ones.
Yeah.
So yeah, it's variable.
I would love to get an occasional boring normal one.
Exactly.
That would be fantastic.
I know I should not complain. Yeah.
Anyway, we're getting ahead of ourselves here, Christine, because we're not up to the imaging section yet. We're still in the pathology section. And the next part of the pathology section, I'll keep reading. So, variants, parathyroid lipoadenomas can happen. And then the
Hmm.
other one is atypical parathyroid tumors, which are borderline neoplasms of uncertain malignant potential. The next section is markers, so biochemical markers. This is useful. So, parathyroid hormone is typically elevated, normal range 10 to 55 picograms per mil, often with raised serum calcium. However, even a normal PTH may be inappropriately elevated if calcium is high. So, values above 25 picograms per mil are generally considered non suppressed in this context. Adenoma size may correlate with PTH level, but biochemistry alone cannot distinguish adenomas from multiglandular disease or parathyroid carcinoma. PTH levels in carcinoma are, however, often elevated 5 to 10 times above the upper limit of normal,
Yeah.
so greater than 300 picograms per mil. And the final little sentence here, normocalcemic primary hyperparathyroidism can also occur, and urinary calcium excretion may be assessed to support the diagnosis.
Totally. So those little subtle variations that you're talking about, normal calcemic hyperparathyroidism and a normal PTH with hypercalcemia, really important to remember that the PTH can be in the normal range, but it's actually abnormal because it should be suppressed if
Mm.
you have hypercalcemia. Yeah.
We have officially finished the pathology section of the
Woohoo.
article now, Christine, which means we're up to radiographic features. Now, I know you're very keen to get to 4D CT, but first up, we have to talk about ultrasound. So the article reads ultrasound is a common first line modality for parathyroid adenoma localization. Utopic adenomas are often well seen if greater than 1 centimeter and typically lie adjacent to the posterior or inferior thyroid margin. Sensitivity is lower with smaller adenomas, ectopic position, adjacent thyroid nodules, or prior neck surgery. And then the first little section here is on grayscale imaging. So typical adenoma features include oval, well defined nodule, 0.5 to 3 centimeters in size. Most are in the range 1 to 1.5 centimeters. Homogeneously hypoechoic relative to thyroid. They're often very hypoechoic in my experience. Thin echogenic interface separating it from the thyroid. And the final point here is larger lesions may appear lobulated or partly cystic. Yes, sometimes I think that thin separation, that thin echogenic separation between the adenoma and the thyroid is described as being the capsule, which I'm not sure is actually correct, but it is definitely a useful feature on ultrasound. In terms of those other features, hypercoic, ovoid, sometimes lobulated definitely matches my experience. But I'll also add that I've seen quite a few parathyroid adenomas that are quite elongated and almost hug the thyroid rather than being this round kind of
Mhm.
nodule. And they can sometimes be tricky ones, not just on ultrasound, but on other modalities.
I don't do ultrasound at all anymore. I look at their report for localization before I interpret the 4D CT, and sometimes if there's a discrepancy in the size of lesions, I'll look at the
Mhm.
images, but I don't do the scans. So
Yeah, I understand. I dream of that. But but I will say that the resolution of ultrasound, compared to the zoomed up, slightly blurry things we see on CT, the ultrasound is amazing. You see this beautiful nodule, all the little internal details, the little cysts within them. You see that polar vessel. It makes the little bugger look like it's alive. You know what I mean? So,
you love your radiology. I love
yeah.
that.
Anyway, I should keep reading here. So, atypical or uncommon ultrasound features include cystic degeneration, ranging from minor to greater than 50% of the lesion being a cyst, and coarse calcification. I think the cystic formation can actually make it a little bit harder on CT when you're looking at, because that's
Yeah,
going to influence your
totally.
density when you're measuring Hounsfield units. The next section here is Doppler. So, internal or central vascularity is present in 85 to 97% of primary disease cases. Polar feeding vessel at one pole, usually from the inferior thyroid artery. That's an important one. Low resistive index, correlating with elevated PTH levels, apparently. And an arc or rim vascularity pattern is seen in some cases. And then we have a little sentence here that says smaller adenomas and secondary hyperplasia are less likely to show these features. The polar vessel can help distinguish adenomas from lymph nodes, which have hyaline vessels, and thyroid nodules, which have no polar vessels. Yeah, I think the polar vessel is interesting because it applies not just to ultrasound. It's certainly a feature that we use on a CT as well, and it can really help increase diagnostic confidence. Christine, I know you don't do ultrasound, but do you want to describe that a little bit more for people?
Oh, totally. So the polar vessel is one of the things that we do use in 4D CT because you see it coming into, hence polar, one of the ends of your elongated lesion that you think is a parathyroid adenoma. It is helpful sometimes to follow. If you see a really prominent vessel, I tend to follow them and see if it's going into anything. And I've never, we talk about lymph nodes having a hylar central vessel, but I've never found a prominent vessel running into a lymph node. Like
Yeah,
I,
yeah.
so I know you see it on ultrasound, but I don't really see that on CT.
Adenomas, they're neuroendocrine tumors and they're hypervascular. So they
Mhm.
have a lot of blood supply to them. So having their own feeding vessel makes a whole lot of sense. Last little bit of ultrasound here. So additional techniques. Shear wave elastography may show lower stiffness than thyroid. Microvascular Doppler techniques like SMI and MVFI can improve detection of slow flow and small feeders. This is superb. Microvascular imaging is what SMI is, and the other one is microvascular flow imaging. I have no experience with these. And then finally, contrast enhanced ultrasound may show early peripheral enhancement followed by central washout.
You know, I love the way, by the way, superb microvascular imaging. That is
I
such a
know.
great name. But I don't know anything about basic ultrasound. So this advanced stuff is like,
When they name it superb microvascular imaging, it's definitely named by a manufacturer. That is definitely a
totally.
marketing gimmick, that one.
It's perfect though. I love
It
it.
is. Now you'll be very glad to hear that we've finished the ultrasound section, Christine. And we've made it to CT.
Yes.
So get excited. Let me read here. 4D parathyroid CT plays a key role in preoperative localization of parathyroid adenomas. It offers higher sensitivity than ultrasound or sestamibi, particularly in reoperative cases or when adenomas are ectopic or small. Now it says here, see the separate article on 4D parathyroid CT for protocol details and interpretive approach. So there's a separate article on Radiopedia for this, but instead of jumping across to that separate article, Christine, given that you're here, I was thinking maybe you could give us a quick rundown on what 4D parathyroid CT is in terms of the technical details before I read on a bit further.
Okay, so there are two parts to this. And one part is, obviously, you got your multi-detector CT, blah, 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 and you can look up a million articles to get what's your KEV and everything. The thing that I find is most important is you need to spend some time with your technologist when you start doing these scans. And it's really, really important because you want them to do the same thing every time for every patient and get the timing right for everything. Get the patient with their arms, shoulders down as much as possible. If it helps, you can do a string or something, a rope that they're holding in their hands that goes around their feet, something to help pull the shoulders down. You want the patients to be in quiet respiration, and you preferably, you want to be kind of careful with this, is making sure that the needle that you're going to give the injection through is on the right side, okay, not going in the left side. And that's to minimize the streak artifact in the superior mediastinum. So those are that kind of like going through that with your technologist and making sure that they can get your patient calm and in the right position and quiet breathing, no breath holding, and try so that you get exactly the same position just makes your interpretation that much easier. But shoulders down, right-sided injection, also critical for allowing good evaluation where you get all your beam hardening or streak artifact in the superior mediastinum. So really critical. And then we do the pre-contrast. We tend to start kind of at the angle of the mandible, but I definitely have some cases where I've got the pituitary gland and I have an MEN syndrome with a pituitary adenoma, no joke, in the scan as well as parathyroid adenoma. All the way down to the carina pre-con. And then you want to do we do 3 identical, but a lot of people stop in the superior mediastinum. We go all the way to the carina on the pre-contrast, around 25 seconds after injection and around 70 to 80 seconds for the venous phase. So we do those 3 phases. That's it.
Yep, that sounds pretty similar to what our protocol is, so that's good. The timing ever so slightly different, maybe 5 seconds out on ours, but that's as long as you're doing it consistently and you know what to expect on your scanner, then you're going to have a good experience. I'm going to read a little bit more about 4D CT here from the article, and then I'll get you to maybe share your actual approach to interpreting these scans, Christine, because they can be challenging but rewarding ones to interpret. So I'll read on. So typical multi-phase features of adenoma on 4D CT include low attenuation on the non-contrast CT due to low iodine content, intense arterial enhancement, typically 130 to 180 Hounsfield units. They are neuroendocrine tumors after all, and then rapid washout on the delayed phase. So while highly specific, this classic pattern is actually only seen in 20% of adenomas. So other supportive morphologic features include a little list here. So oval or lobulated nodule adjacent to the thyroid, that's what we're looking for to a large degree. A polar feeding vessel, as we already discussed, usually from the inferior thyroid artery, and larger size greater than 13 millimeters, favoring that it is a single adenoma that you're dealing with. And then a little list here, pitfalls of 4D CT include cystic adenomas or parathyroid cysts with atypical enhancement, so reduced enhancement, intrathyroidal parathyroid glands mimicking thyroid nodules, as we've discussed, lymph nodes mistaken for adenomas, quite common, progressive enhancement rather than washout, enhancing veins or small vessels seen in cross-section, and then small lesions less than 7 millimeters or multiglandular disease. And then the final little sentence here, newer CT approaches include low-dose protocols, dual energy CT, radiomics models, and hybrid imaging. There you go. So with all of those background points in place, Christine, now it's time for you to tell us about your interpretation approach to a 4D parathyroid CT.
Okay. All right. So when I'm starting to read the scan, I usually want to have checked what's the calcium, what's the PTH. We did mention before about a really, really high PTH favors parathyroid carcinoma. when I've seen them, they've always been in the thousands, like really high.
Hmm.
But I usually want to know what that is. I want to know if the other studies have found a lesion before to have an idea, but also if they're discordant, anything going on there. And then the patient age. And I mentioned that before, because if they're a young patient, chances are it's multi-gland disease because they have a genetic abnormality. All right. So then I set up my packs in a very specific format, and you're going to think I'm a little OCD, but let's just go with it. Okay. So I have my screen set up with 8, 4 on the top, 4 on the bottom. I have the top 3 are going to be the non-con, arterial phase, venous phase, axial images. Below that, coronal, non-con, arterial phase, venous phase. And then the 2 on the right, I have the arterial and venous of the sagittal. The sagittal, I don't find helpful for finding lesions, but I find it really helpful for localizing the lesion. Okay, so once I've got set up, I'm going to zoom those axials up really big. And I'm talking like most of the screen is like this, a really, really big view. And I'm going to start looking, but again, it kind of depends whether there's any localization scans before. If there's no localization scans at all, it's most likely going to be a run-of-the-mill one. It's not going to be a weird ectopic. But nonetheless, we start big, and my eyes are focusing on the arterial and the non-con next to each other. And the non-con is really, really important to me to have it right next to the arterial, zooming together, scrolling together. And I tend to start parathyroidal, top to bottom, looking at those axial images. And anything I find, I'm then going to look at the venous phase, and then I'm going to look at the coronal plane as well and localize in all 3 planes. So I want to be super, super specific about my localization too. So I want to say exactly where they are, with if they're lateral to the esophagus, if they're in the tracheoesophageal groove, if it's right at the hypopharyngeal esophageal junction. And I put arrows on everything. I tell them exactly which image slices in 3 planes that I see it on. So my reports are super, super specific.
Yeah, it's interesting that you mentioned putting an arrow on it, because I listened to a surgeon speak on this recently, and he said he only wanted 2 things from our 4D CT interpretation. He wanted the distance above or below the cricoid cartilage, because that's what he palpates at surgery, and then he draws a line from there as to how far above or below it is going to be, and an arrow on the adenoma so that he can see where it is and work out the depth. And obviously the depth is important for the chance of encountering the nerve in those kind of settings. The other thing I wonder is, do you measure the actual Hounsfield units, or are you just visually looking at what it does on the arterial and the venous, or is there a cutoff for how high the Hounsfield units should be on that arterial phase that you think, ooh, this is likely an adenoma?
So I used to measure Hounsfields all the time, and I
Mm.
used to measure them relative to the thyroid gland, and now I don't. And I think I don't know exactly why I stopped doing that. It doesn't seem to be helpful to me anymore to measure. So I do it all as a visual. I want to go back with that, because sometimes the pre-con is where the answer is with that. And I
Mm.
guess if you don't have a thyroid, that's when I start getting nervous about things enhancing. So everything
Yeah.
I do is a visual comparison to the thyroid gland. But if they've had a thyroidectomy, you get one of those nasty cases, prior thyroidectomy, prior
Mm.
parathyroidectomy, I still got primary hyperparathyroidism. You've got no comparison. That's probably a time I might pull out, okay, let me measure the Hounsfield of this. Is this a lymph node? How much is this enhancing? But generally, I
Yeah.
just do a comparison to thyroid on the pre-con.
My approach is, if I'm thinking, oh, this could be a lymph node, I'll find another lymph node in the scan and measure the Hounsfield units on that, on the same phase, or find a little a vein and measure that. So that's really the only context that I'll use the Hounsfield unit in, is when I'm trying to compare it to one of those other things. And then other than that, it's a visual relative to thyroid type thing.
Yeah.
I'll let you finish with your
Yeah.
approach now.
But those are some of the, the little tricks that you have to use. And you just mentioned the vein as well, because veins can be problematic too. And
Mm.
I think the answer, we started by talking about how this is not about making a diagnosis. This is about finding the thing that is there somewhere. And so everything around that thyroid is either going to be a parathyroid adenoma, a lymph node, a vessel, or some sort of exophytic thing coming from the thyroid gland. So you need to be able to kind of put every little thing you see into one of those groups.
Mm.
And if it doesn't kind of work really well for you with the enhancement phase, sometimes those are the things I say, this may represent a lymph node, but I describe exactly where it is in case in case A, it's the only thing, or B, intraoperatively the PTH doesn't go down and they need to go looking for something else. I've given them a
Yeah.
potential second site. But anyway, so you find the first one, describe the daylights out of it, and then you look for the second one, and then you look for the third one, and then you look for the fourth one. And the problem ones are the ones where you can't find anything. So, or
Mm.
you find a little 7 millimeter thing and you're like, maybe it's a 7 millimeter adenoma, or maybe this is just the first of multiple. But if you can't find anything, then I, double check superior mediastinum. I double check the paraesophageal region, particularly in the superior mediastinum, because that's a place that I have to force myself to go back and think about. Check the retropharyngeal area, and then check the thyroid. And then I go to the coronal plane and I do the coronal plane, the pre and the arterial phase next to each other slowly, because sometimes they sit like right under the thyroid. So you've got your thyroid gland and they kind of cup it right underneath.
Mm.
And on an axial plane, you'll miss it every day of the week. But on a coronal, it's really easy.
Yeah, that's
So,
the kind of thing I was
yeah.
describing on the ultrasound. That kind of, it just sits under it and just cups it,
Right.
doesn't it? Yeah.
It cups it.
Yeah.
I mean, the inferior glands love that. So that's,
Mm.
and you feel like such an idiot when you can't see it on the axials, and on the coronal. It's so obvious. Okay. So once you've found everything, I then go to the venous phase and read it like I'd read an XCT. So look for masses and adenopathy, look at the bone windows, look at the lung windows. And then there are two other things that I think are really important to go into a radiologist report for a parathyroid, or for that matter, a thyroid study. And that is if there's a right-sided aortic arch. And that's because there's a risk of them having a non-recurrent laryngeal nerve. And therefore it's greater risk of being injured surgically. And I take a look at the larynx and hypopharynx. So if they look asymmetric, like maybe their vocal cord is dysfunctional, it's not working properly, you want them, this is what you're doing, is you're protecting your surgeon,
Yeah.
so
Keep
that
it.
they can get a vocal cord function preoperatively done. So otherwise, postoperatively, when the vocal cord function is not so good, they're not suing your surgeon. So my surgeons love that. So those two things are things that are just to help the surgeon a little on the end of the report.
Awesome tips. Thank you very much. Now, it's not currently in our article here, Christine, but I have heard people speak about the 3 patterns of enhancement. So an A, a B, and a C for the attenuation values for adenomas. I think A is that classic pattern that we described earlier that's only seen in 20%, the arterial enhancement and then the washout. Are these patterns something that you find useful to think about when you're reporting?
I think they're really helpful for people, especially when they're starting reading parathyroid scans. And I used to be super strict with these, using type A, type B, and type C. So type A is, as you said, that arterial phase enhancement that then washes out on the venous phase. Type B is when it is not enhancing as much in the anterior phase. So it's either isodense to the thyroid or a little less dense, and then it does wash out. That's B. And then C is when there's no arterial phase hyperenhancement and no delayed washout. So they kind of look a little bit more like lymph nodes with the type C.
Mm.
And so I use that terminology to group them into, this is consistent with a parathyroid adenoma, suspicious for, or a possible parathyroid adenoma. And that's, again, just using, whether you feel really confident or not. I used to be really, really strict with type A, B, C enhancement pattern, Barbara. And I don't know, maybe I again, just like measuring things, I think over time, I just feel really a lot more confident about some things than others. And so it's either this is a parathyroid adenoma or this is suspicious for, if
Mm.
I'm not sure about it.
Very similar to how I've evolved with this as well. Should we move on? That's enough for CT. Should we move on to MRI? Before I start reading, I should say that I have no experience really with using MRI for parathyroid localization. How about you, Christine?
So we used to do a lot of MR with dynamic contrast enhanced imaging. And in the old days, so even older than me, neck MRs used to be read a lot for the thyroid and parathyroid at our place, used to be read by the chest people. And then this amazing chest radiologist retired. And so the rest of the chest people didn't want to do them and gave them to us. So we invented this dynamic contrast enhanced MR, thinking that would be fun. And it was fun. They're not easy to read. I'd much rather read a 4D CT any day of the week. But
Yeah.
we did do them. And now the only time we do MR is we also do fluorocholine cases as a research sort of thing. And so I read the MR part of those. But
All
yeah,
right.
it's harder than 4D CT.
All right, so here we go. I'll read the section here. MRI is not commonly used as the first line modality due to lower spatial resolution and vulnerability to motion artifact, particularly at the thoracic inlet. It can be useful in selected cases when the other imaging is inconclusive or contraindicated, such as localization of ectopic glands or in reoperative cases. So, parathyroid adenoma signal characteristics on MRI include on T1, typically intermediate to low signal, although you can have high signal from subacute hemorrhage or low signal from chronic hemorrhage or fibrosis. On T2, they're typically very hyperintense, but you can again have low T2 signal in fibrosis or old hemorrhage. And the marked T2 hyperintensity may correlate with elevated PTH levels. Post contrast usually demonstrate avid enhancement, and the ADC values, adenomas usually have higher ADC values, so in the range of 1.5 to 2, compared to thyroid and lymph nodes. And next little bit here, it says, it is reported that since most adenomas demonstrate high T2 signal intensity, the addition of contrast on MRI does not significantly increase detection rates. And then final sentence, dynamic post-contrast 4D MRI may show enhancement patterns similar to 4D CT with reported sensitivity up to 80 to 85%, although spatial resolution remains lower.
So that line that addition of contrast does not significantly increase. I'd love to dig deeper into the study that came up with that. That is not my experience. I think the contrast adds everything. As I said, the MRs that I look at now are with fluorocholine, so they're non-contrast MR. With fluorocholine, and I think it's really hard to feel confident differentiating them from lymph nodes. On those studies, we don't do diffusion, but diffusion's really hard the lower in the neck you go. So this idea that I'm going to be able to use my ADC values, I don't feel really confident with that. But anyway, it's interesting, but I think it's hard to imagine trying to do a neck MR on its own without contrast.
Yeah, I was going to say, unless they're way, way brighter than lymph nodes or veins, then I can't see you getting away without dynamic contrast.
Yeah.
All right, let's move on now to the next section, Christine, which is nuclear medicine. And it's definitely something that is used at my institution as a preference first up over 4DCT. And so personally, I have some experience looking at them, but no experience reporting them. So what I've decided to do here, Christine, is I'm going to phone a friend. So right now, hopefully, magically joining us is radiologist and nuclear medicine specialist, Dr. Sally Esser. Welcome, Sal.
Oh, hello, and thank you for having me. Thank you for summoning me. I guess, you know, that in future you just have to say nuclear medicine 3 times and I just magically appear on the but you know, I love being here to talk about nukes and all the sparkle with it. So thanks for having me along.
Yes, excellent. So I asked you if you could help with the nuke med portion of this discussion, and I've got the feeling that you said yes, but you were probably most excited to meet Christine.
See, he does this. He rats me out. But yes, no. Christine's certainly been a radiological hero of mine, and I'm a bit of a fangirl. So thanks for that, Dixon. But it's really lovely to be doing Readful with you, Christine. Thank you, and thanks for having me. But I have to actually kind of correct you there. I actually did get to meet Christine at RSNA last year at Chicago. I kind of accosted her in the corridor, and it was kind of funny, I thought, because I actually met Christine before I met you, Andrew. So that was a bit of an interesting one, but thankfully we've rectified that now. But the internet
Yes.
works in interesting ways, I think.
Yeah, speaking of Nuke Med, we actually went and saw Beetlejuice the musical the other weekend. So Sally and I
Strong recommendation.
definitely met in person now. We've been to a musical together. All right, I reckon that's enough of a little intro here. It's time for you to do a little bit of work, Sally. So you've got to go into bat for Nuke Med and how important it is for parathyroid localization. So let me read what is written here in the Radipedia article, and then you can chime in with some extra details. So it begins with scintigraphy. So technetium 99M sestamibi is a lipophilic radiotracer that accumulates in tissues with high mitochondrial activity, including parathyroid adenomas. It is commonly used for localization, particularly in ectopic glands or locations less accessible to ultrasound. Technetium 99M tetrosphosphon is used as an alternative to technetium 99M sestamibi in some practices. The specific nuclear medicine protocols used are highly variable, with options including single tracer, dual phase washout, dual isotope scanning, and combinations of these approaches. I have no idea what all this means. Dual isotope tracer techniques combining thyroid scintigraphy, so using technetium 99M pertechnetate or I123, and technetium 99M sestamibi are employed to increase specificity in patients with thyroid nodules and to distinguish small adenomas from adjacent physiologic uptake in the thyroid. Whether technetium 99M pertechnetate or I123 is used is determined by local availability and practice preference. Visual comparison or quantitative subtraction can be used for interpretation. And then the final little bit here is SPECT-CT imaging is now standard in most parathyroid scintigraphy protocols, imaging the neck and upper thorax. It offers superior anatomic location and diagnostic imaging compared to 2D planar imaging alone. Now, there is an extra little section here on some of the details of how the sestamibi scans are performed, the dual tracer scans, etc. But I'm going to skip it because it is variable from location to location, and I'll jump straight to this bit. Typical scintigraphic findings on technetium 99 sestamibi include early uptake with retention on delayed 2-hour images, focal tracer activity near the thyroid poles or in ectopic locations, e.g. the superior mediastinum. And then before I let you have a little go here, Sally, limitations include false positives from thyroid nodules or lymph nodes, false negatives in small lesions, rapid washout, or low mitochondrial density, for example, chief cell predominant adenomas. And then finally, false negatives in multi-gland disease, even with SPECT-CT. All right, that's it for the scintigraphy section.
Take a breath. Oh my goodness. Okay, so firstly, I bet you're regretting asking me to rewrite the section now. So basically, this is kind of one of those tough ones. I have to confess that when you asked me to come on today to talk about the nuclear medicine parathyroid studies, I was a little bit nervous for pretty much the feeling that we're getting now. Like, I love to be able to come in and teach a really nice, clear message and go, this is how we do it. This is how I do it. Use some practice pearls. But parathyroid scintigraphy is just so variable, and so variable such that when I was doing my nuclear medicine training, they always ask us to write a couple of essays, and they picked something quite controversial, and they picked parathyroid scintigraphy for one of my submissions. And honestly, like, it was just like one of those most complex essays to write. And I had to kind of do some mental gymnastics. And the European Society and the American societies, they all kind of have different approaches and don't give you one clear way. So let's demystify that a little bit. And I think it's kind of really, it speaks to nuclear medicine as a specialty. Like, one of our greatest challenges is that everyone does things different. We have different access to tracers. Like in Australia, even though I would love dearly to use iodine for thyroid imaging, we just don't really have it available. The cost and the logistics are prohibitive. Really, the thing is you just need to have, that we've got the sestamibi, 2D imaging, early and delayed time point. SPECT-CT is really important. You can do that early, delayed, both. I tend to do it at the delayed, and then you can kind of massage things a little bit. If you need to come back and image at 4 hours, that's part of my job when I check the studies. So we tend to troubleshoot as we go. The thyroid imaging, really important for that visual comparison because of the cystoscopy kind of, being taken up by both of the glands. But, it's a little bit of a tricky one here, isn't it? Sorry, I couldn't demystify it further.
No, I liked the term massage things because that's what it is like for me when I look. Because I look at quite a lot of Sister BB scans. Some of them are great, right? You can spot this nicely highlighted blob, and you're like, oh yeah, awesome. And
Yeah.
then I look at others, and I can barely see a thing or
Yeah.
absolutely nothing.
hmm
Why is it so variable? Is it related to the too many chief cells and not enough Indians? That's probably not a saying that
Goodness.
I should say anymore. But is it
We'll just
due
leave
to
that one
that? Is
there.
it due to the
Well,
physiology of them?
yes, in part. So it's actually kind of like one of those complex questions. And it's such a great question as well. Like, why can't we see it always? So the physiology, certainly one thing. And we know we're looking for small lesions. They can pop up in unexpected places, exactly as you saw from earlier in the podcast or the talk that we can have more glands, we can have them in different places, they can be small. And then kind of
Hmm.
that speaks also not only to the physiology, but also the nature of nuclear medicine, single photon imaging itself. And so, for those who are kind of new to nuclear medicine, we have general nuclear medicine, which is single photons. Technetium 99M is kind of our bigger workhorse tracer. The spatial resolution is inherently less for a few reasons, in that it's more difficult to kind of narrow down our energies, and there's a bit more impact of the effects of scatters, lower signal to noise ratio, and the way that the cameras are set up, you can only really go down to a certain kind of size. So the images are going to look a little bit more blurry. You're not going to have that beautiful, crisp spatial resolution you get with CT. It's a combination of all of that. And then also the specificity of the tracer as well. I kind of mentioned that the thyroid's going to take it up. So we're either doing visual subtraction, like putting things side by side to try and
Mm.
work out which blob is behaving differently, or using the computers to help us if we're using iodine. And I'm feeling a bit of a segue coming on. It would be really lovely to have, a more specific tracer to help us out with this, to give, more higher spatial resolution as well. Maybe something to do with PET, Andrew? What do you think? Is there something coming up in the article?
I I don't
Where are
know.
we
So
going with this?
all I do is read. All I do is read. The next section is PET imaging. Oh, it is. So
Oh.
PET imaging. So F18 fluorocholine PET CT is increasingly used, particularly when prior imaging is inconclusive or in reoperative cases. Fluorocholine is taken up by cells with elevated phospholipid metabolism, including hyperfunctioning parathyroid tissue. The technique has shown particular value in localizing small or recurrent adenomas and in cases of negative or discordant conventional imaging, multi-gland disease, and or concurrent thyroid nodules. Features include higher sensitivity and spatial resolution than sestamibi, and early uptake with clear localization.
Makes it sound promising, doesn't it?
Hmm.
I'm excited. Read
It
on, and
does.
then I can kind of, wax lyrical about it, I think.
So there are other PET tracers that may be used in select settings. So C11 methionine, limited availability, niche role, it says. F18 FDG PET, I've heard of that one, may show uptake but lacks specificity. And then gallium 68 dotatate, somatostatin receptor targeting, occasionally useful in MEN1 or atypical glands. And then finally, hybrid 4D PET CT or PET MRI may assist in complex or ectopic cases.
I'm so happy to be able to come onto the podcast and talk about this, because really bringing in F18 choline has just been a bit of a revolution in my practice. And Christine, I heard you talking about how you're using it as well, comparing it with the 4D CT. Like, it's really kind of changing the game for our referrers. They're really excited by this. Anecdotally, we're hearing it's improving surgical outcomes, particularly for these more complex patients. You can't find the adenoma on other imaging. It might be obscured, difficult to detect, or if they've had a thyroidectomy or a lot of surgery, for us to be able to go, oh, there's the dot, it's right there next to this surgical clip, is really useful. And it speaks to kind of nuclear medicine more broadly, in that we're moving into this era of, targeted molecular traces. It's not
Hmm.
just FDG, seeing whether something is metabolically active or not. We've got a bunch of new ones coming in. So the choline for the parathyroid adenomas, dotatate for somatostatin you saw up there,
Hmm.
prostate cancer. It's just really, really exciting. Kind of coming back to the we just kind of shorten them to choline. I know it's fluorocholine PETs, but we don't find the adenomas every time. But I'm certainly noticing a much better hit rate. And even when we go back to the cystoscopy image, you might have just had something very subtle there, but it wasn't enough to call it.
Mm.
Or you go and look at the 4D CT and something that was called a thyroid nodule because it was behaving that way actually is focally avid on the choline. So we're really kind of helping there. And we're constantly, of course, going back to the previous imaging. And a really great other thing that we can put in there, particularly for the camera that we use at our site at Royal North Shore, is that we can do ultra low dose CT. And even half the doses. And so we've been actually imaging a few pregnant patients coming through, and it can make a huge difference. And we're keeping the radiation doses low and being able to kind of help with that surgical localization, giving the risks in there. So I guess kind of thinking about technically what we're doing, we're early days, so we're kind of still using the dual time point. So early and delayed, we're kind of doing a bit of audit to see what's going to be best going forward. I like it. It helps me with lymph nodes. But, watch this space. I think it's going to be becoming more common. And I really do feel like it's having a bit of a difference in my practice. Christine, what do you think?
So we've been using it for a few years, but it's on a research protocol. And some of the cases, like, my head exploded when you looked at them. And you're exactly right. You go back to the sestamibi or you go back to the 4D CT, and it was something that you were kind of either couldn't call at all or you're a little bit wavering over. Suddenly it's like pinpoint, there it is, go for it. We've had a couple of the parathymatosis cases, really rare, but this is people who end up with like 10, 15 parathyroid lesions. It's awful. So I had one recent run and we couldn't find anything, but they often are really tiny dots on this 4D CT. But I remember the first case I had of that with fluorocholine, and the patient had already had multiple adenomas resected previously, and the fluorocholine found 5 more. And my head exploded. I was like, okay, this is wild. So I'm excited too.
It is amazing to see just how specific it is for those little adenomas. That brings us to the end of the nuke med section here. Indeed, that brings us to the end of the radiographic features section for this article. So just a couple of little sections to go. Sally, are you happy to stick around until we get to the end?
Yeah, sure.
Excellent. All right. So this next section is treatment and prognosis. So surgical excision is the treatment of choice for parathyroid adenomas and is curative in over 95% of cases. Minimally invasive parathyroidectomy is preferred when preoperative localization is successful, with intraoperative parathyroid hormone monitoring commonly used to confirm adequate resection, so typically a greater than 50% drop from baseline. Current guidelines support surgery not only for symptomatic patients, but also selected asymptomatic individuals, including younger patients and those with elevated calcium or reduced bone mineral density. Non-surgical treatments, such as ethanol ablation, are rarely used and are generally reserved for patients who are not surgical candidates. Christine, minimally invasive surgery is really where it's all at these days, and that's what our imaging is dedicated towards. A little 1 centimeter incision directly over where that
Beautiful.
adenoma is. Yeah, and you can deliver it, birth it directly out that hole. I was listening to a surgeon recently, as I said, who was saying, not only does this minimize the risks of the surgery, doing this minimally invasive technique minimizes the scarring, and therefore when you do further surgery or further imaging, it keeps it nice and clean, but it also turns a procedure into, a 15-minute type thing as opposed to a traditional hour-long operation. So there's lots and lots of benefits. So yeah, this surgeon was actually saying though that he doesn't actually use PTH monitoring at all these days for his operations because it was slowing them down, waiting for the results. And in fact, the cure rates are so high that it wasn't really worth doing the PTH.
That's an interesting theory. Our place, they still always do the intraoperative PTH, and again, the same rule, looking for a 50% drop. But I can see that, especially if it's 15 minutes and if it takes you 20 minutes to get your labs back.
Yeah,
no, it makes a lot of sense.
Right, just 2 sections to go here, and then everyone can head off. So differential diagnosis. For non-ectopic adenomas, consider eccentric thyroid nodules. So these will have more variable echogenicity rather than the hypoechogenicity of a parathyroid adenoma. They're often less vascular, and they usually lack that polar feeding vessel. So lymph node is the next one on the list here. So they typically show a fatty hilum on ultrasound, and on CT, a central vessel rather than a polar vascularity, and they enhance usually less prominently, but they can be very similar. The next one is blood vessels. So on 4D CT, small veins can mimic nodules in cross-section, so make sure you use all of your planes to try and work out. And as I said earlier, I like to measure the density of other veins in the area, and if it perfectly matches the thing that I think is a nodule, then I start to doubt myself. The final one here is esophagus, may mimic a lesion on ultrasound, so look for movement, internal gas, that mucosal stripe. I guess that's with inexperienced ultrasound operators where you might confuse that. The next section is in ectopic location, so this is the differential to consider, a sequestered thyroid tissue. So this may appear very similar, typically shows higher attenuation on the non-contrast CT due to the presence of iodine, obviously. And then thymic tissue located in the anterior mediastinum, it's often triangular or bilobed with less rapid enhancement. The last little bit here is the differential diagnosis for multiple enlarged parathyroid glands. So obviously we're considering, and this is the whole point of the study, multiglandular parathyroid disease, and then secondary parathyroid hyperplasia. Obviously, we know that usually clinically these will be chronic renal failure type patients. The final section is another one of my favorite sections in Radiopedia article. It's called the practical points. So practical points are the imaging approach varies by institutional preference, as we've seen here that Christine's seeing a lot of 4D CT, often as a primary modality. I'm still seeing 4D CT after ultrasound and cystoscopy have been performed. So there definitely is variation in practice. Ultrasound is typically the first line, however, probably worldwide. 4D CT or cystoscopy added if ultrasound is non-localizing. Small adenomas less than 1 centimeter may be occult on ultrasound. So I think we all know that as an important thing that limits ultrasound, but also ectopic ones limit ultrasound. Combining two modalities often improves localization and helps detect multiglandular disease. The next point is ectopic parathyroid glands are usually only identified on 4D CT or functional imaging rather than ultrasound. And the final point, in patients under 50 years, consider a genetic cause, e.g. multiple endocrine neoplasia, which increases the likelihood of multiglandular disease, as you pointed out earlier, Christine.
This is awesome. I feel like I'm going to go back to reading these scans with this like extra energy now. Like I feel really, this is fabulous. I feel like I've learned a ton.
Oh my goodness, me too. I've learned so much. I do a lot of nuclear medicine, but I am a diagnostic radiologist kind of at heart, but I haven't been doing a lot of these recently. So I think I feel like I need to jump in. I've been a little bit inspired. So thank you both for magically summoning me to be part of the session. It's been great.
You're very welcome. Thank you, Sally. Thank you, Christine. Thank you, people, for watching and for listening. And I'll see you both again sometime soon.
Thanks so much, Andrew. And really good to see you, Sally. Hope to see you again soon. In real life.
Definitely. Lovely to see you both. Thanks for having me.
She'll track you down at a conference, Christine. Don't worry about that.
Good. Just if you hear footsteps, run. But thank you so much. It's been lovely chatting with you both.
It's always so much fun catching up with Christine each year for the conference. She's actually already emailed me, Gaylard, about talks that she's working on for next year's conference.
Excellent.
And that's before the conveners have even officially invited her to speak. But I have a feeling that she may be welcome to speak at the event for as many years as she likes. And the same goes for Sally as well.
Yes, absolutely. They're both outstanding teachers and really good role models too, I think. So I know this was a long episode and you don't want to have too much talking. So I'll keep this really short and super relevant to what we've just listened to.
Yeah.
Have you seen the latest Final Destination movie? Bloodlines, I think it is. It's the 7th or 8th in the series.
This sounds super, super relevant. So is it about a man-eating parathyroid adenoma or something?
Nope. But, I do love a good adenoma as much as the next guy, but that was a lot of adenoma talk. So anyway, the premises of Final Destination franchise is that some character at the start of the movie cheats death by having a premonition and avoids a mass casualty event. Like in the very first Final Destination, it's about a plane crash and he gets off the plane along with a bunch of people. And then the plane goes on to explode. But all the people that should have died, but that they got off the plane because of this premonition, don't die. And so death is like, hey, you cheated me and now I've got to kill you.
Yep.
And death does it in this really overly engineered Rube Goldberg mechanism kind of crazy way. of
Oh, yeah,
accidents
you don't want to make
happening.
you don't want to make it too obvious or easy.
It's all very super gory, very silly. Anyway, in this last movie, there's an MRI death, a protracted MRI death. And I don't want to give any spoilers because it's actually really funny and quite well done. But it is annoying to see just so many errors there are in it. I think in this case, it's not because they didn't do any research, but because they wanted to tell this particular gory story, which wouldn't have worked. But for example, the magnet is off and there's no magnetic field. And then they turn it on and the Teslas start ramping up from 0 to 0.5 to 1. And there's this big bar that's going up. Yeah, and there's the tractor beam sound effect in reverse. Yeah. And then when it gets to 3 Tesla, it says, warning, entering research strength or something. And then it gets up to 7. And when they get up to 7, there's some other, exceeding research strength magnet. The room isn't shielded at all. So metal from all the surrounding rooms, like 20 meters away, is getting sort of a bit pulled, which I don't think that would happen because, the fall off of the magnetic field is really very sharp. Even at the door of the magnet room, even if you didn't have shielding, I don't think you'd notice anything. But you kind of need that because you can just imagine all the different metal objects that would be around in a hospital. Have a watch, even if just that scene. And the machine looks good. Like it looks like a proper MR unit. It's not just some cardboard cutout. Usually they use like a CT mock-up. This looked like an MR mock-up. And how the physics otherwise works is pretty good. So I give the scene 5 out of 5 despite the fact that the Teslas ramp up. And the movie overall, I think it's a solid 4 for the franchise. It's a good one.
4 Teslas out of 5.
Yeah.
Sounds good. Do you have anything that's actually related to this episode to chat about here, Galen?
No, not really. Other than I think that Sally's kidding herself if anyone would ever invoke a nuclear medicine physician by saying their name 3 times. Just kidding. I felt like it's a while since I poured a little bit of lighter fluid on the smouldering beef that I have with Sally over Nuke Med. So, no, I'm sure everyone would always be asking.
I actually think it would be cool to just be able to say whatever the name of the specialist is, and then they magically just turn up next to you because you're looking at a case and you're like, oh, I wonder what the Nuke Med physician would say about this. Yeah. And you just kind of like, oh, that's all right, I'll put out the report anyway. But it's like, if they were here, I would have just clarified something with them.
You might have to wear little ruby slippers like in Wizard of Oz.
I already do wear ruby slippers. What are you talking about?
I'll tell you what, there is one thing that I'd like to say, and that is you mentioned the help the surgeon in terms of things to say in reports that are helpful. I think that can be generalized to help the referrer, but it should be kind of the radiologist's version of the Hippocratic Oath, because if there's one thing that all of our reports should be doing is helping the referrer, because it's through helping them do their job that we get to help patients. And you read so many reports that not only aren't very helpful, but sometimes they're almost passively aggressively unhelpful to the referrer because you're kind of like, oh, well, this was a stupid request, so I'm going to give you a narky, passive-aggressive kind of report. So helping the referrer, very good.
You know what I do for that situation is I write my passive-aggressive line and then I delete it. So that kind of
get it out of your system.
It makes me feel good. But then I delete it from the report so that it doesn't actually get out there.
Yeah, I usually put myself on mute and dictate it so that the registrar in the room can hear me being all narky. And then and that way you can even really get it out of your system. It never makes it to paper.
What happens if the registrar actually thinks that's the report you put out and they're like, Frank Gaylard says this. So that's what I say. Because some of those ones where it's like it was on the x-ray, like you could see it on the x-ray, and then you've done a whole CT and the CT request, didn't actually say what was on the x-ray because they hadn't bothered to look at it or they've misinterpreted it. And it's kind of like, as seen on the x-ray, there is a
nipple shadows. As reported on the chest x-ray, the opacity in the right lower region is a nipple shadow.
A mention of nipples, and therefore it's time for us to wrap this episode up. Gaylard, it's a rule. It's a new rule.
It's a new rule.
How can people get in contact with us?
Well, you can email us at podcast@radiopedia.org with any ideas and or feedback. And you can also join the Radiopedia community chat by visiting radiopedia.org/community.
Yes, you can write into us just like Yusuf did. So Yusuf writes, "Hello all, I am a radiologist in South Africa and
Can
I've
you do a
recently
South
found..."
African accent? That's really insulting.
I don't think I can. I reckon if I try to do a South African accent, I will sound maybe like a New Zealand. I reckon it'll stray, and I don't want to do it. I don't.
Is there the equivalent, auto-tune for pitch? Is there the AI equivalent for auto accent
of
where you can
accents.
take your accent, your voice, and just turn it into a caricature accent for anything?
Well, let's see. If I'll just read this in my normal voice, and then if when people are listening to the podcast, it comes out as South African or something else, then we'll know that the technology does exist. So Yusuf writes, "Hello, I'm a radiologist." I got you there, Gayla.
Very good.
You weren't expecting that. All right, here we go. Hello all, I'm a radiologist in South Africa and I've recently... He's still laughing. Hello all, I'm a radiologist in South Africa and I've recently found out about your podcast. I'm dipping into all the old episodes, so I'm probably a bit out of sync. I listened to the episode about whole body MRI and PET, and at the end, you played an AI-generated song that used MRI sounds. I thought it was pretty good, and the lyrics were hilarious. I'm not sure if you've received feedback already, but there is a song that uses MRI sounds as a backing track, and it's very good. It's done by Charlotte Gainsbourg, and it's called IRM, which is the French abbreviation for MRI. Those French are so backwards.
Personally, I love how contrarian the French are. Well, not contrarian, but they refuse to take English acronyms because AIDS, for example, in French is SIDA. And they don't say LOL, they say MDR, which is mort de rire, as in I died laughing. So good on them for sticking to French.
I'll continue reading here. So this is a little Wikipedia extract from the album it comes from. In late 2009, Gainsbourg released her third studio album, IRM, which was produced by Beck. Gainsbourg's head injury in 2007 influenced the title of the album IRM. During her brain MRI, she began to think about music. This is a quote. "When I was inside that machine," she said, "it was an escape to think about music, its rhythm, it's very chaotic." And then Yusuf goes on to say, "Give it a listen, enjoying the podcast, and keep up the great work." And now you had a listen, didn't you, Gaylard, to this song?
Yeah, it's actually really good. It's very MRI sound. Like it's definitely not just inspired, but it's a little bit too much like listening music in our old MR reporting room, which was close enough to the magnet that you'd always hear the background. So pretty much for years, any music that I played while reporting sounded like this because it was music overlaid with gradient echoes switching. No, it is good, actually. I enjoyed a listen.
Yeah, it's really good. I might actually try and play a little bit during the outro if copyright allows us to do that. I'll continue reading here. And if you want to help
it's not like
support...
they can demonetize this podcast, can they?
No, exactly. That's what it actually says on YouTube. It's like, you can't put any ads on this. I'm like, great, whatever. I'll read the next bit. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses or conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle-income countries. And what else can people do to help us out, Frank?
They can also help out by leaving a 5-star review in the podcast app of your choosing.
Yep, that would be fantastic. This is episode 70. I was speaking to my daughter earlier. I was like, I'm recording a podcast today. She's like, oh, what episode are you up to? And I'm like, 70. And she's like, oh, that's almost a milestone. 75 is the milestone. And she's like, but you could mention 70 if you want.
I mean, yes, why not?
So let's claim it. Let's claim every episode is a milestone from here on in.
I think we should, all prime numbers should be milestones, surely.
Does prime numbers become more frequent though?
No, they become less frequent, which is matches, because you can't claim milestones at the same frequency.
No,
like 10th episode is something, but 110 doesn't mean
no.
anything.
But I feel like we need milestones more frequently. Psychologically, that might help. Anyway, we'll catch you all again sometime soon in the reading room.
Yes, indeed. Stay rad, everyone. Stay rad.
Stay rad. I'll see you again soon, Frank. Now, everyone listen in for a little bit of IRM, or should that be MRI, inspired music from Charlotte Gainsbourg.